Assalamualaikum warahmatullahi wabarakatuh. I am Asnurhanna binti Saleh. Matric number 910815045190. My learning center at Kota Baru, Kelantan. And today I want to discuss regarding Schizophreniform Disorder under the topic of clinical practice of mental health NBCP 3912. So this practicum was taken place at Psychiatric Department, Hospital University Science Malaysia, Kubang Kerian, Kelantan. Throughout this assignment, I would like to discuss regarding the Schizophreniform Disorder, which is a psychosis disorder that is similar to schizophrenia. Unlike schizophrenia, this Schizophreniform Disorder is only lasts 6 months or less. And it also has a potential to cause psychotic manifestation such as delusion, hallucination, and erratic behavior. Therefore, researchers has discovered 3 different illnesses that causes the same symptom, and the diagnosis will be based on how long the symptom lasts. We can refer to the table. Brief psychotic episode symptoms has lasted no more than 1 month, and schizophrenia, the symptom will persist after 6 months. So schizophreniform disorder, the symptom will only last for 1 to 6 months. During my practicum session, I encounter with a patient. He is a 27 years old Malay male and working as a training consultant for Newport recruits in Port Klang. This young man was brought to emergency department by police officer accompanied with his mother and sister with the chief complaint of abnormal behavior characterized by talking irrelevantly, poor sleep associated with sleeping in sitting position, and neglect self-care for the past 3 months. So this patient was admitted to the psychiatric ward under Borang 3 and Borang 4. During the history taking session, actually this is the first episode of abnormal behavior. According to his mother and sister, that the first episode of abnormal behavior was noted in 2014 when the patient was 19 years old during his final semester in Institut Latihan Kemahiran Kota Baru. He was noted to have change in behavior by his batchmate and lecturer, which is characterized by quiet and not communicating with anyone. He also isolates himself in his room, neglect self-care, become irritable and verbally abused, but still able to attend college. He also at that time accused his lecturer for sabotage him by hiding his project work and asking him to redo it again. And the symptom resolved after 3 to 4 months. Because the family member thought he was possessed, therefore they sought help from Ustad and Bomoh lah for traditional healing method. Never seek for medical psychiatrist treatment. Then after 3 to 4 months, he returned to his premorbid state. After 8 years, this is the second episode lah. He just joined in this new job for 6 months. The recent stressor is there. He had difficulty in doing paperwork and presentation. He is also not well with computer. So he had difficult analyzing and interpreting articles and to prepare speech for his superior. He will call his sister for assistance and inform that he is stressed with work. So in early June, his housemate and superior noted changes in behavior of patient lah. He started to become quiet, not communicating, isolate himself, acted abnormally, suggest disorganized behavior. According to his mother, his friend said that he will go standing in seminar for the whole seminar and taking bath in rain while holding handphones, sleeping in sitting position. He has persecutory delusion towards his higher officer because he thinks that the higher officer sabotage him at workplace, and also towards the family members. He thinks that his brother cheat his money, his brother impose him, their family want to poison him and monitor him via GPS and CCTV, and there was a chip inserted to the body. He was brought to the psychiatric in Usain and was started on antidepressant, which is tablet escitalopram 10 mg online. But family member unable to serve the medication to patient regularly due to the patient's condition, which is he acted aggressively at home. On the day of admission, patient strongly refused to go to hospital for appointment and verbally abused when family members forced him. Therefore, family lodged a police report. Okay, on admission, mental state examination was performed. Patient was very thin, built young man, appropriate to age, long nails in some finger, and has yellow stain over the shirt, neck, and back and ears due to saffron cream. Wearing t-shirt inside out, cap and slippers. Look very sleepy, kept on yawning. But patient was calm, cooperative, and having fair eye contact. Speech mostly relevant and at times irrelevant, but coherent with slow rate, monotonous, low volume, and short answer. When asked the patient mood, he said he was happy and scale was 9 over 10, but the effect was not appropriate with the mood. Patient was noted to have persecutory delusion, no suicidal thought, and no possession. According to his mother, pre-morbidly, patient was very neat, tidy, religious, friendly, open for discussion, has good relationship with family and friends, very hardworking, and has good occupational history. Now he was working. Previously, he was working as a fire watchman, as freelance at oil and gas Qatar for 3 years, and Container National Bali at Top Bali for 1 year. So now he was a training consultant, just entered this new job under JPA. He searched the job by himself and did resume and attended interview and got the job. He denied taking any drugs, smoking, vaping, and alcohol. Unfortunately, before this, he had undergo several motor vehicle accidents during his 18 years old, 20 years old, and 23 years old. He had a history of LOC, loss of consciousness, during the MVA, but no CT brain was done at that time. He has no known medical illness, and since this is the first time this patient was brought to the medical intervention, medical psychiatrist treatment, so this is the first episode that documented properly. So the past psychiatric history was on June 2022 when he go to the GP and was referred to the Usain, and he came to the Usain and started on that escitalopram 10 mg online and tablet clonazepam PRN, and this time he was admitted. Briefly on the family history, patient has 5 siblings and he is the 4th. Mother and the father work as teacher and penghantar notis mahkamah, and both are pensioner. The 33-year-old elder brother married with 2 sons, doing own soil test business and staying in Kota Baru with his parents and wife and 2 sons. The 32 years old single sister worked as a nurse in Arab Saudi, and 30 years old single sister worked as administrative officer in oil and gas Qatar, and his younger brother 20 years old studying nursing in Tun Shan Hospital, Kuala Lumpur. In his family, which is mother, father, and the siblings. There are no non-medical illness and no psychiatric illness, but he had two paternal aunts with bipolar disorder and epilepsy that has follow up under Hospital Raja Perempuan Zainab II and has history of admission to psychiatric ward. So we can say that this patient has predisposing factor from the genetic loading. During physical examination, roughly patient vital sign was stable, pain score was 0, lungs, cardiovascular system and abdomen system was normal. Okay, I have done the cognitive evaluation, which is this patient had normal cognitive lah, because the orientation was good, attention was good, memory was intact, calculation can able to perform simple maths, general knowledge was good, knows regarding the COVID-19 and vocabulary is appropriate to the level of education. Okay, throughout the examination, I can say that this patient has all three factors that affecting the disease lah. So from the predisposing factor, he had biological genetic loading from his paternal aunt that has bipolar and epilepsy, and he also has precipitating factors, which is he noted that he has stress at workplace and the insight was so poor. Psychologically, patient was having poor insight. So these three factors that affecting the patient to have and to develop psychotic symptom. We had done investigation to this patient to rule out any medical illness problem. So we had done electrocardiogram and noted he had no any acute ischemic changes. The full blood count also normal. The renal profile also normal, and urine for drug tests are all negative. So this patient is we can say that the act of behavior, the abnormal behavior is not due to the medical illnesses, and we have ruled out any medical illnesses that has symptoms like this patient is sitting is sleeping in sitting position. So in other medical illness, we can say that maybe patient is having acute pulmonary edema or fluid overload. So with all the tests and assessment that we have done, we have noted that the patient has no known medical illness lah, no any other medical illness. It is solely the psychotic changes in a patient. Also done the psychometric assessment using hospital anxiety and depression scale, Beck's depression inventory, brief psychiatric rating scale, which turn out to become all normal except the score for brief psychiatric rating scale, which is 33/126, which is in mildly ill category. So we can say that provisionally the diagnosis was schizophreniform disorder with good prognostic features. This is because the patient is having persecutory delusion with disorganized behavior and speech, and the symptom is last for 3 months for this episode, and impact functioning of self-care, impact his occupational and interpersonal relationship. And I can come up with two differential diagnoses, which is major depressive disorder with incongruent psychotic features. Initially, the patient mood scale was 4, tearful at workplace, has recent stressor, had insomnia. This is all the MDD symptom lah. Decrease in appetite, diminished interest in activity, and he also was started on antidepressant. So this is one of the differential diagnosis that I think this patient is might having it. So the number two was substance-induced psychotic disorder, but family and patient claim patient was not taking any drug and the urine for drug test was negative, but only the presence of delusion, which is a short duration of time and sudden onset, that make me think that there is something that can go to the substance-induced psychotic disorder as a differential diagnosis for this case. Okay, the management for this patient in emergency department, patient was triaged to yellow zone for better surrounding and privacy. Patient was escorted with police officer and family members. Vital sign was monitoring. Patient family members were interviewed to obtain chronology of symptoms, patient conditions throughout duration of illness. And because of the aggressive behavior, patient was given IM haloperidol and IM midazolam-stat. Patient refused to eat, drink, poor oral intake, kept quiet and looked lethargy lah. So this case was referred to psychiatric for further management and planned for admission to psychiatric ward under Form 3 and Form 4. In view of unmanageable by family members, patient refused for medication and poor oral intake, and also anticipation of aggressions. So in psychiatric ward, patient was started on Seroquel 300 mg on night, and nursing care was carried lah. Vital sign monitored daily, behavioral chart monitoring, encouraged orally, and also weight monitored in ward because of the poor oral intake. So in ward also we give the education given to the family members and patient regarding the illness and treatment. And patient encouraged to do occupational therapy in group, so that patient had developed interpersonal skill relationship for patient, such as karaoke, seated aerobic and drawings. After having treatment in ward, patient progression in ward was very good. I can say it was very good. After few days of psychosocial therapy and medication, patient looked more stable. No more depression looking. Patient had more comfortable talking coherently, relevantly, eat and sleep well, obey instruction, looks very clean, started to pray, which is initially patient has poor insight, but family support is very good lah. He talk by phone using video call every day. Then he was aware of his condition and medication purpose, and patient willingly to join our voluntary activities, baking and car wash, and he said that he enjoyed working. No more persecutory delusion, no aggressive behavior, and denied any hallucination. So counseling with family members was done, and they understood regarding the importance of medication for patient, and build more trust between patient and family. Actually, this patient is lucky because he has very good family support, and patient is intellectually good. So he understood on how to manage precipitating factors at work, manage his stress. Okay, for a conclusion, actually, schizophreniform disorder can progress to schizophrenia. In some patients, maybe the symptom will subside, but 2 out of 3 people with schizophreniform disorder will then develop schizophrenia. According to Miles and Drake, patient with schizophreniform disorder will require medication, and the most importantly requires psychotherapy to help them to recover from schizophreniform disorder and remove them from the risk of schizophrenia. So in some cases, people with schizophreniform disorder also have symptoms of depression, which subsequently will increase the risk of suicide. So this is very important to have psychotherapy and counseling for any patients that having psychosis and having what we call the manifestation of psychotic disorder. The earlier we get psychotherapy and counseling, the earlier patient will the more good prognosis will be. And one of the thing is the family members support and surrounding. So in my patient, this patient recovered from having schizophreniform disorder and having any manifestations of psychosis. Mostly he get positive support from his family members. So it is very important to prevent any unwillingly circumstances. Okay, that's all from me. I hope sir will receive my presentation, even though I know that this is a late submission, and I am sorry because I have so many hard times to finish my assignment and finish my practicum session. But I hope this is enough for me to complete my study, and thank you so much, sir.